Hello. Uh,
Yes, yes, Aradhya, you are audible.
so, good evening, ma'am, sir, and everyone. I would like to say the lump in the abdomen.
Yes,
Mhm.
continue, Aradhya.
Yes, sir. So, let's start. My patient is a 65-year-old patient named Mumtaz Sheikh. She's a resident of Chandanshore, Hausa Road, and she's a labor by occupation, a Muslim by religion, and belongs to the lower socioeconomic status. She actually came with the complaints of loose watery stools since 4 months. Those were her only chief complaints.
Okay, next.
Yes, ma'am. Wait 1 minute, ma'am. So the history of present illness states that the patient was apparently all right. She was all right 4 months back when she started developing loose watery stools. The frequency was approximately 10 to 15 times per day, most of the days, and in some of the stages, the patients also started having constant dull aching pain in the left lower abdominal region, which generally aggravated on eating and relieved partly after passing stools. So, and she also has a history of loss of appetite since 2 months, which is not that significant. So, the negative history states that the patient has no history of fever or vomiting. There was no trace evidence of jaundice, night sweats. There was no melena, passage of roundworms, constipation, breathlessness, convulsions, steatorrhea, or a burning micturition. Mm, Going ahead with the past history, she has hypertension since 10 years, and there was a hysterectomy procedure done on her 5 years ago. So there was no she doesn't have any history of diabetes or a past TB infection or asthma or any spurious diarrhea. Personal history states that she has adequate sleep, her bladder habits are regular, and she has no addiction of any sort. The family history is not that significant. uh, Starting with the journal examination.
Okay,
Yes, ma'am.
Aradhya, just let's go to a history of presenting illness and the chief complaint first.
This is the chief problem.
Yeah, come. Is there any thing which you suspect in lower socioeconomic status coming to this case? Why socioeconomic status is important in this case?
Generally, people from lower socioeconomic status might suffer from chronic infections, which
Okay.
might result in diarrhea, like chronic diarrhea for 4 months.
Okay. And what more? In an abdominal case, this is matlab now you are able to understand the patient is having some pain, what is stool. So you are it's not a respiratory case, it's not a serious case, it's an abdominal case, right? In
Yes,
a,
ma'am.
countries like India, what can you suspect in situation of low socioeconomic status or overcrowding or what can you suspect?
In country like India, we can suspect tuberculosis, which is common in lower
Yes,
socioeconomic status.
yes, yes,
Uh,
yes, and
yes, and continuous
MEB,
infection.
yeah, MEBS you can suspect.
Yes, amoebiasis. I can suspect giardiasis
Okay.
or a chronic
Giardiasis in
cytomegalovirus.
India, in India.
Okay, so I
Yeah, one
can
second. Yeah.
suspect if
Okay, okay.
in provinces of Odisha, filariasis is more common.
Filariasis.
Uh, so sorry, ma'am. So in
Are you
GIT,
telling filariasis?
no,
The
ma'am.
GIT, I am asking about GIT infection. Yes, yes.
Yes, ma'am. So GIT, TB is common, cytomegalovirus is more common, and
Typhoid infections are also common, but this presentation is unlikely because of typhoid.
yes, ma'am, this is not present in typhoid.
Yeah.
But a few
How does typhoid?
carriers,
How does typhoid? Aradhya, how does typhoid illness present?
typhoid illness might present with a stepladder pattern of fever with abdominal pain,
Yes.
and sometimes constipation can might occur.
Diarrhea. Diarrhea. Then.
In I've read somewhere that in some books it's also written that carriers of typhoid might present with diarrhea, chronic diarrhea.
Okay. Okay. And what more abdominal symptoms?
In late stages, perforation might occur,
Yes. Yes. After 2 weeks, you see, after 2 weeks, operations will happen. After the convalescent stage, after 2 weeks, which is then operations are common in typhoid.
or a typhoid
Next,
ulcer might
let's go.
develop.
Yeah, yeah, typhoid ulcer, which later leads to perforation.
Yes, ma'am. This is the HOPI.
Any other differential diagnosis, Aradhya, for chronic
Uh,
loose
my
motion loose stools?
like I said, for chronic loose motions, my I'll start with the infective etiology.
Apart from
As she
infectious
belongs to
etiology?
TB especially,
No, no. Apart from
and
infectious etiology,
apart from infective etiology, I can go for some loose watery stools. If melania would have been present, then ulcer, a peptic ulcer.
so less like hepatic ulcer presenting as a loose motion for since
You are
3 to
telling
4
the
months.
pain in lower abdomen, right, Aradhya?
Yes, ma'am, lower abdomen.
Septic ulcer unlikely present with pain with lower abdomen, right?
So yes, ma'am. So
It's a
pain in
it's a
lower
female. What more can you see?
uh,
Loose motion since
female.
3 to 4 months. Any other history? Any other differential diagnosis?
Mm, an ovarian mass can be present.
As a loose motion?
Uh, loose motion.
Irritable bowel syndrome? Any inflammatory bowel disease?
Yes, ma'am. Yeah. Yes, sir.
Inflammatory
IBD and IBS can also present as
ulcerative
loose motions. Also presents as loose motions.
Any
colitis.
immune compromised state?
Yes. If she is suffering from HIV, then diarrhea is a common feature.
So at this age is also
Okay.
6 years old. You can think in terms of also loose motion, not loose motion, alternating bowel habits. So more likely also colonic, any colonic malignancy.
Yes, sir.
Okay.
We call it altered bowel habits. Always the patient doesn't have diarrhea. The patient have constipation, later diarrhea, constipation. She feels she have partly passes stool, but she doesn't have full emptying, feeling of full emptying.
Yes. Yes, ma'am.
Then, what is the history of what is the history of loss of appetite?
She said she has a lots of appetite since 2 months, but personally, I would think
Okay.
that it is a kind it is psychological in nature. There was not like apparent. No, it is not related to the pathology.
Why do you think so?
She says that she doesn't feel
So,
like eating anything.
based on okay. Based on your history, which you have taken, history of presenting illness, what is your differential diagnosis, Aradhya? You
So
might have thought something is there, no?
IBD would be the first thing in my mind, as it's a chronic
Okay.
condition, and there was no uh,
Okay.
example, like there was no trace evidence of any constipation, chronic constipation, and there was continuous diarrhea. So ulcerative colitis can be one of the DDs.
Okay.
But
But do you think ulcerative colitis presents in stomach
ulcerative
only? What is the most common age group of ulcerative colitis? Any inflammatory bowel disease at any time? Suddenly it
Uh,
presents from its
a young age group.
young age group continue
Ma'am, I could not hear it. Can you please repeat?
you are any previous similar.
Hello,
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 Aradhya.
Aradhya, am I audible?
ma'am. It's lagging a bit. The network.
Let me correct with other phone.
So what is the age group of presentation of ulcerative colitis or any inflammatory bowel disease? So usually it will in the middle age group.
Middle age.
Okay, our patient is little bit old, so usually in the middle age group it will presenting as a inflammatory bowel disease.
Yes, sir.
So the constant dull aching pain in the left lower abdomen since 4 months, which aggravated on eating and release partially on passing stool. So you are telling constant dull aching pain and also you are telling relieving partially on passing stool.
Okay, sir.
So she's
Aradhya, one more thing. The patient presented at 60 years. In past history, you have not mentioned any similar complaints in the past, right? How does ulcerative colitis present suddenly at 60th year?
Yes, ma'am. It generally doesn't present immediately.
If the patient is having tuberculosis or even malignancy, won't patient have loss of appetite, Aradhya? What is the mechanism of loss of appetite in this patient? You know anything, anyone, any chronic disorder? Why does patient have weight loss? Why does patient have loss of appetite? Anything you remember?
Ma'am, maybe due to the increased metabolism.
Okay.
Uh, there might be a weight loss due to
No.
the increased metabolism. Ma'am, actually don't know the
Okay.
mechanism of loss of appetite. Why does it occur in chronic conditions?
Anyone, anyone whoever there in this meeting, why does loss of appetite or loss of weight happens in this chronic etiologies of malignancy? Anyone? You
There's decreased
remember
absorption,
anything?
so there's decreased absorption of whatever intake is happening, so the appetite is naturally
Okay.
reduced.
Okay. So you might not have breast cancer. Still you have weight, still have loss of appetite. What happens in breast cancer with decreased absorption? It doesn't correlate, right? In breast cancer or thyroid cancer or anything. Any cancer you will ask the patient to have reduced weight. Anything you remember? So whenever this sort of inflammation happens, our body has cachexin. There is a mediator called as cachexin. Ismail, I can connect from different places. Could you proceed?
yeah, your voice is breaking. So in malignancy, so it is a term called as cancer cachexia. So due to releasing of tumor necrosis factor, many interleukins, so you'll be having suppression of your metabolism, decrease in absorption. So those are the factors responsible for your cancer cachexia. Okay, more than your absorption or more than your decrease hamper. Usually, if GI malignancy is there, upper GI malignancy is there, predominant symptoms will be patient will having any issue with dysphagia will be there. If there is a CA stomach is there is a decrease in the absorption will be there. So along with that, there are tumor necrosis factor TNF alpha, and there are interleukins also released along with the multiple cytokines. So those are the factors responsible for your loss of appetite. Okay, Aradhya.
Yes, sir.
So dull aching pain in the left lower abdomen since 4 months, which aggravate on eating and release partial on passing stool. And she has a history of loss of appetite since 2 months, and there is no history of fever. Why you are asking about history of fever?
Fever to rule out TB or
Okay,
infective
any other?
pathology.
Okay, any other thing?
Um, mm,
One is your infective
fever.
pathology.
Any other thing? An abscess?
Abscess from
Any abscess which might have developed due to uh, infection or a psoas abscess.
okay, one is your along with your tuberculosis, you might get psoas abscess. Then
Uh, can't think of any other pathology, but
say basically if you're having pain in the left lower quadrant, loose motion, okay. So left lower quadrant, your inflammatory bowel disease also ruled out. In inflammatory, you might get fever. In inflammatory bowel disease also you might get fever, and also if you're having any diverticulitis, okay, you might be having fever.
yes,
Okay, one of the differential types of it will be diverticulitis.
yes, sir.
Okay, and apart from that, why you're asking instead of vomiting? Aradhya vomiting.
Vomiting. So, vomiting, sir. I can think of peptic ulcer disease. Uh, when any obstruction. Generally, an obstruction might present as vomiting.
Okay, then
If it is an intersusception or a volvulus.
so to rule out any other acute pathology. Okay, it could be intersection, it could be any obstruction. So you might get vomiting. And suddenly you are running to jaundice, night sweats. Why jaundice?
Jaundice, sir. Actually, I was ruling out any primary metastasis of gallbladder or HCC.
See, basically you are telling pain in the left lower quadrant and loose motion, and suddenly you are telling gallbladder metastasis, HCC.
It doesn't correlate now. It doesn't correlate with your case.
So
Yes,
when you are
ma'am.
sticking to one pathology, okay, you should first ask history regarding that. So suppose if you are thinking pain in the left lower quadrant, loose motion, so you'll be having GI pathology, and
Yes, sir.
suddenly you are running to a hepatic metastasis, gallbladder metastasis, jaundice. That is not correlating, no.
Yes, sir.
So what will be your next history? ठीक है, melena, passage of round of first. See, your history should be systematic. First, you have to rule out infective pathology, then inflammatory pathology. So that is melena is fine. Melena, what is melena?
Passing of black tarry stools.
So melena is your medical term, no? You can't use in the patient language.
Yes, sir.
Okay. If there is
Melina
any
is
kind,
anyway blackish discoloration of the stool. Now you have not asked about fresh blood in the stool also. It can be simple. Patient might having simple fissure in ano. You don't know. You have not ruled out all that, right?
No, ma'am. I didn't rule out
Yeah.
fissure
So
in
you
ano.
have to. So you have to ask blackish discoloration of the stool, any reddish passage of reddish color stool, or anything. And why did you ask fever with you have to also write 12 about fever with evening rise of temperature. So tuberculosis might be ruled out, and any lymphoma can be ruled out. The B symptoms, right, of lymphoma.
Yes, ma'am. I asked about
Anorexia,
night sweats.
yeah, night sweats, fine.
so you are sure
And
no
what more?
history of fever, no history of fever with evening rise of temperature. So it should be one line. So next coming to or else first vomiting will be first, or else next will be fever. So last will be your jaundice. And
Yes, sir.
third will be a passing black color stool or passing worms in the stool or fresh blood in the stool. And you are telling no history of chronic constipation. What is acute constipation? Aradhya?
Uh,
Is there any term acute and chronic
Actually,
constipation?
no, sir. Actually, it is there's only chronic constipation.
Okay, there is only one constipation. Okay. And
What
you are
is
telling that
constipation, Aradhya?
Constipation means difficulty in passing of stools
Is
or
there any is there any specific frequency, this many amount of stools the patient should pass, or any such sort of thing?
no, ma'am. I don't have any idea about that.
Anyone in the group? What is constipation? Take a difficulty passage of stool, that is constipation, right? But according to this functional guidelines, now there are two types of constipation: functional constipation and normal constipation. Based on functional constipation, they'll tell itna number of frequency hai, to you will call it constipation. They tell in surgery they'll tell three or less stools per week. In medicine they'll tell two or less number of stool frequency per week. Okay.
Yes, ma'am.
Yes.
so why suddenly burning micturition?
Uh, Burning micturition. I asked if probably there's mass in the bladder or ureter.
So that is causing your
Mass
diarrhea
in
and pain.
bladder is Aradhya, how does bladder mass first present with burning micturition or hematuria?
Actually, it presents as hematuria, ma'am.
Where is your hematuria history about hematuria? And what more?
So
It can be a kidney mass. Na? You can think ectopic kidney is present. Might be kidney may be in I think pelvic region or anything or below. It can be malignancy of kidney also, na?
yes, ma'am.
Then if at all it's a malignancy in kidney, what all features you will ask?
Uh,
What is the triad of RCC?
Hematuria, loin pain, sorry, flank pain, hematuria, and ma'am, I can't remember the third one.
Okay. What is Dietl's crisis? Where do you see Dietl's crisis in kidney? Anyone Dietl's crisis? What is Dietl's crisis? Aradip can be hydronephrotic kidney also, right? Which is in loin.
Yes, ma'am. It can be a hydronephrotic kidney.
If it is the same patient you are dealing with a female. Imagine if this is a male.
Yes,
So
ma'am.
what will you suspect if it's a male? Imagine if it's a male and there is you are not able to see a testis in the left scrotum. So what will you suspect?
Undescended testis or
It,
ectopic testis.
will ectopic testis be palpable this much?
No, ma'am.
Then what happened in ectopic testis? What happens in ectopic testis as the age grows?
It might become carcinogenic.
Seminomatous changes.
Yes, ma'am.
So if it's a male, you should always see the testis region. That's why in your general examination of private parts, examination of genitalia is very important.
Yes, ma'am.
Yes. What more
Aradhya,
things have you missed in history, Aradhya?
Hello.
Ismail, continue.
why Aradhya steatoria?
Steatoria to rule out, sir, malabsorption.
Steatoria to rule out malabsorption. Which malabsorption?
So, so Whipple's
What is Whipple's?
Whipple's disease is a chronic malabsorptive condition.
So you will get steatorrhea and malabsorption syndrome, or where you get steatorrhea typically.
Steatoria we can also see in giardiasis, sir.
Apart from that,
Uh,
see if there is basically if there is a defective metabolism of fat metabolism, you will get steatorrhea.
Pancreas.
So along with
Yes,
your
sir.
any enzyme deficiency of lipase, okay, pancreatic lipase. So that is due to chronic pancreatitis or any fat metabolism disorders are there, you will get steatorrhea. So steatorrhea is also
Yes,
your
sir.
medical term. So you should not use the word steatorrhea. And no history of breathlessness, no history of convulsions. Why no history of breathlessness or convulsions?
Sir, all are regarding the secondary meds. So they are not anything related with the mass present currently in the abdomen.
So, okay, so see, basically you are having history of only loose motion since 3 to 4 months.
Yes, sir.
So if someone is coming with you loose motion since 3 to 4 months, you are telling them breathlessness, convulsion if you are asking that history, and if you are telling them malignancy only in the initial stage,
No, sir.
so there is no any other history in your apart from your loose motion suggest you have any malignancy in this patient.
Yes, sir.
Okay. In examination,
Loss of appetite.
also during examination or during your final examination, whatever the history patient is giving, don't go towards the final diagnosis and take history regarding that, or take your differential
Yes, sir.
diagnosis regarding that. You can tell, sir, I have examined the patient, I have felt the mark, so after that I have taken history retrospectively.
Yes, sir.
Okay, so that will be your
What
answer.
we are
Not
saying is your history and your examination should correlate with each other. You should not be like history telling no history about something and suddenly in examination you say something. It should not be like that.
Yes, ma'am.
okay. So first negative history should be there is no history of fever with evening rise of temperature, or there is no history of loss of appetite, loss of weight. Next history is any passage of black tarry stool or passing of any round worms, and there is history of constipation, or there is loss of weight. And apart from that, if there is any passing throaty fatty stools, and later you should ask the history of jaundice, breathlessness, convulsions. So your metastatic history should be at the end.
Yes, sir.
Okay. So going to next part, past history.
In past history, sir, she has a history of hypertension and hysterectomy was done 5 years ago.
So when you are telling hysterectomy, no, so you should mention whether it has open hysterectomy or whether she has went vaginal hysterectomy or she has done a laparoscopic hysterectomy. So that is important.
Yes, sir.
So why there is a hysterectomy? Any previous surgery is important.
So to know the surgical status of the patient or any other adhesions, if adhesions are
So
present.
adhesions are also causes one of the causes of chronic abdominal pain. Okay, it might present as your constipation, not loose
Yes,
motion,
sir.
but it may might present as a constipation. Okay, patient will be having history of chronic non-specific abdominal pain. So
Yes, sir.
past history of tuberculosis infection. Why past history of tuberculosis infection?
Reactivation of primary infection might occur or extrapulmonary spread might occur to the site in that's why.
What is the most common site of extrapulmonary tuberculosis
Mm,
in GIT?
extrapulmonary. Sir, ileocecal junction.
Ileocecal junction. Why ileocecal junction?
So because it is narrow and the presence of Peyer's patches.
It is narrowest region and presence of there are multiple Peyer's patches. So how abdominal tuberculosis will present, Aditya?
Sir, it will present as an um, ulcerative. It will present as an ulcer or it might present as a constricting ring.
See, basically a patient won't come, no, I'm having ulcer or I'm having constricting ring. How patient will tell you they are having non-specific abdominal pain.
Yes, sir.
Okay, continuously they are having abdominal pain, dull aching pain. Continuously they are having dull aching pain with fever, with loss of weight, loss of appetite.
Yes,
Okay,
sir.
so they'll present like a chronic non-specific abdominal pain. So apart from there are there are different types of abdominal tuberculosis. What are the types of abdominal tuberculosis?
Uh, Type of hyperplastic tuberculosis, ulcerative tuberculosis,
Then So either hyperplastic or ulcerative. This is related to your bowel. Okay. Apart
Yes,
from
sir.
your hyperplastic and ulcerative, there is a
Uh,
peritoneal tuberculosis,
yes, sir. Peritoneal tuberculosis.
and there are enlargement of tubercular lymph nodes. What are the tubercular lymph node enlarged called as? So
I don't know, sir.
it is called as tabes mesenterica.
Yes, sir.
Okay, it was called as tabes mesenterica. So how ulcerative tuberculosis present as?
A transverse presentation, clinical presentation, sir.
Clinical presentation.
It, sir, pain, chronic pain, along with diarrhea.
What will be the immunity of the patient?
The patient will be immunocompromised.
Okay, next. So which one is the most common site? Like which site you will get
Ileos,
ulcerative? Ileocecal junction is most common. Okay, depends on
yes,
the
sir.
patient's
Ileocecal.
depends on the patient's immunity. So patient will be telling you chronic non-specific abdominal pain, fever, loss of weight with loose motion. So whenever their patients are having ulcers in the last small bowel or large bowel, they'll give history of you. Okay, either it could be melena or they will tell you they are having any passing fresh blood in the stool due to because of
Yes, sir.
ulcer. Okay. So how
Why
hyperplastic?
Yes.
IC junction is most common zone for tuberculosis?
Sorry, ma'am. Which? I couldn't hear.
No, IC junction. Why IC junction is most common cause of tuberculosis? Asking you.
Due to the abundance of Peyer's patches, and it is a narrow portion.
And how hyperplastic tuberculosis present are?
Hyperplastic TB will present as
Apart from all your generalized symptoms, hyperplastic tuberculosis present as your mass per abdomen.
yes, sir.
Okay, predominantly they'll be having mass at the right iliac fossa.
Yes, sir.
Okay, so that will be your presentation. And how patient has peritoneal tuberculosis present as?
Enlarged lymph nodes
So that is your fourth
and
classification. How tuberculosis peritoneal tuberculosis present as?
peritoneal
So patient with peritoneal tuberculosis presenting as
pain,
abdominal
sir.
distension. No, abdominal they will be presenting as abdominal distension
Yes, sir.
due to tubercular ascites.
What is the proper term which you use for peritoneal tuberculosis abdomen? You call it something. Any idea, anyone? It's called Duffy abdomen. You know now how after chapati Duff will feel? Exactly, that is the feeling of the tuberculous abdomen. You call it Duffy abdomen.
So on examination, you will be having Duffy abdomen, and it is classically called as your cocoon abdomen.
Yes, sir.
Okay, so predominant symptoms in that patient will be abdominal distension. So usually, enlarged tubercular lymph node stapes mesenterica, you will palpate in the mostly in the children or even thin individuals. They are also present as your mass per abdomen only. Okay,
Yes, sir.
so this is how your abdominal tuberculosis will. How abdominal tuberculosis will spread, Aditya, from pulmonary tuberculosis?
Hematogenous spread, or the
Most
patient
common
might
spread.
Hematogenous,
Most common
sorry,
spread.
not
lymphatic
malignancy. We are asking about TB, na?
Most common
the
spread.
patient might swallow the sputum,
Okay.
or a lymphatic spread might occur,
And
or it might spread from an adjacent organ.
and transcelomic.
mm, Transcoelomic spread might also occur, ma'am.
So there are actually one is patient might consume sputum. Next one is your lymphatic spread. Next one is transcoelomic spread. Another is from your local spread.
Yes, sir.
Okay. So Aditya, why you are asking is it specifically about spurious diarrhea?
uh, to rule out, sir, IBS.
Spurious diarrhea in IBS.
So to rule out a stricture, ma'am.
This question has been this spurious diarrhea had killed my 1 mark in my viva. This is the question exactly the examiner had asked me. I also I'm not able to answer in my second year.
Ma'am,
Where
What
does
is
due,
spurious?
why this terms it's called why does it is called spurious diarrhea? This term is specific for some pathology only. You can't use this term for every single pathology.
actually, ma'am, due to it happens when there's chronic constipation.
Chronic constipation.
Yes, ma'am. Yes, sir. Complete, it is after chronic constipation, severe
Yes,
constipation.
basically spurious diarrhea. Where will you see the spurious diarrhea?
If the term spurious diarrhea is comes, it indicates some pathology. What is that pathology you want to tell us?
Mm,
Ma'am, impaction of hard stools is the pathophysiology.
Carcinoma. Any idea, Aradhya? Why you are at history of a spurious diarrhea?
It's in colorectal carcinomas.
So it is in the colorectal carcinoma. Which side? Which side, Vedi? Right side, left side?
All colorectal carcinomas with you or any specific type of colorectal carcinoma? Which sided colorectal carcinoma? Simple, use some common sense, no?
Of yeah, left side.
Why
So
left
what
side?
is the pathology? What exactly happens? Why do you call it spurious diarrhea?
So the hard stools accumulate there and there's water around it. So it basically mimics like diarrhea, but it's not actually diarrhea.
So, okay. So whenever there is a left-sided annular type of growth, it is leading to it forms the constriction ring. So there will be patient will be having predominant history of constipation. So long-standing retained stool leads to fermentation of bacteria and all. So it will start producing mucus-like substance or mucus-like jelly. So patient will be having constipation, but early morning patient will be having passing mucus-like substance because of fermentation of bacteria. Okay, or because of enteritis, patient will be passing only mucus like jelly substance or patient will be passing any watery substance. Not she or he passes proper stools, but they pass mucus or slimy liquid substance. So that is called as spurious diarrhea. That is classical feature of left-sided annular type of colonic growth or any malignancy. So your stricture per se it doesn't produce any kind of your spurious diarrhea. Aradhya. Okay. So
yes,
that
sir.
is your specific to your left-sided colonic growth or colonic malignancy.
Yes, sir.
So if they are telling you diabetes mellitus, why diabetes mellitus is important?
Uh, Diabetes mellitus produces a lowered immune status
Okay, next.
for a immunocompromised patient, and which might cause TB.
Apart from your tuberculosis, what diabetes leads to chronic diarrhea called as? So it is called as diabetic gastroparesis.
Yes,
So
sir.
patient will be having continuous loose motion. Okay, that is called as diabetic gastroparesis. That is your uncontrolled diabetes. So suppose
Yes,
Aditya,
sir.
if you are thinking it in terms of malignancy, what specific path history you want to ask? Like
Hello.
if you are thinking in terms of colonic malignancy, what specific past
Yes,
history you want to ask Aditya in this patient?
uh, sir.
See, basically,
Past is
colonic malignancies are hereditary, okay? Or these are the familial running malignancies, like
yes,
our
sir.
breast
Family history.
familial. These are the familial disorders. So, in the past history, what you want to ask specifically to these patients? So, past history of any she had underwent any procedures. Suppose past history of any coloscopy she underwent. Past history if she underwent she had removed any polyps in the colon mucosa or any polyps she underwent. past history of any upper GI scope is important. Why upper GI scope is important? So there is a term called as familial adenomatous polyposis. Okay. So in familial adenomatous polyposis, you will be having along with your colonic polyps, you will be having most common polyps extra colonic site is your duodenum. So you will be having multiple duodenal polyps. In that patient will be producing symptoms of your dysphagia or dyspepsia. Patient will be symptoms will be due to because of your duodenal polyps. So any past history of colonoscopy to rule out colonic polyp or she underwent any procedure of polypectomy or past history of any upper GI scopy to rule out any duodenal polyp. So you should ask the history of any polyps in this patient, colonoscopy or upper GI scopy.
And proper syndromic association with breast cancer and uterine cancer also was not mentioned na, in history. At least you should be tell the history is not contributory. The personal history is not contributory. The familial history is not contributory. You have to use that term. No? Not significant. Actually, it should not be used now. It is not contributory. You should.
Yes, ma'am.
So Aditya, why what you want to ask specifically in the family history?
Any previous procedures for polyps or any previous screening done for polyps or anyone
Ar-
suffering from
Aradhya, do
colonic
you
cancer?
think a patient of low socioeconomic status in a place like ours, do you think they will anytime go for screening? What is the history you will ask in families? Exact history what you will ask for low socioeconomic or any socioeconomic status. If any death has happened, if any malignancy has happened, what do you think? Matlab, that's what we'll ask, no? They will tell my grandmother has died after some same similar history. She have died one day suddenly. Then you will correlate, no?
Yes, ma'am.
Mm.
So
So you'll
suppose
ask
Aditya,
maternal sisters, any maternal sisters, anyone having breast cancer and also colonic malignancy. It's a familiar thing, na? Leaf-Romney syndrome, all those.
Yes, ma'am.
Cowden syndrome, all this. Breast get involved, thyroid get involved, colon gets involved, all these things.
Yes, ma'am.
Yeah.
suppose Aditya think like suppose I am educated, okay. So I know if my family member she had died because of any colonic malignancy. Okay. Now you are my treating doctor. So I am at the age of 10 years. I am asking you what should I have done for screening. I have history of colonic malignancy in my family members. So what advice you want to give to me, Aditya?
And you have
That
also tested positive for the gene. Imagine you have tested positive for APG
yes,
gene mutation.
you have tested
So
genes also
the
in me. You,
educated
Yes,
and the
sir.
educated your father was very much worried about you. Or your uncle is worried about you. He comes to you and asks, "See, my son is 10 years old. I have this family history, and we have a family history tested positive for this gene. Then what should we go next? How should I be? Uh,
so what all
what
advice
should
you
be
will
I
give to
doing
me?
next?
So
For
I'm
screening, I would advise occult blood testing and
Arabia, occult blood is for screening in old age, na? At 60 years, you will start fecal occult blood. This is a high risk, very high risk patient who is having polyps. The previous generation is having a lot of polyps. So what will you do here? You want to see, na?
yes, ma'am.
You
So
want to see what
scopy,
is happening at GIT.
colonoscopy can be done every 10 years or 5 years.
every 10 years or 5 years. So at
Yes, sir.
what
See
basically
this thing.
at what age you want to start the colonoscopy? So you want to start the
Aradhya,
colonoscopy as early as possible, up to 10 to 12 years you have to start the colonoscopy.
Yes, sir.
Okay. So after
and the
starting
thing is, na,
colonoscopy,
you don't do colonoscopy in a span of 10 years. These people are very high risk people. 10 years, you see, after 10th year, you see some polyp has grown, it become malignant. There is no use, na? So you will do very frequent colonoscopy in this patient.
so you will start your colonoscopy by age of 10 to 12 years, and every 2 to 3 years you will call them for routine colonoscopy.
Yes, sir.
Okay. So
In
up to
some
what age?
patients, up to
Hello.
what age you will do colonoscopy, Aradhya? Any idea? Matlab, after this age, the risk decreases or some sort of thing.
Don't know, ma'am. Till
Uh,
what age can we do?
See, the simple, this much all came because you inform family history, you have not added the word, the family history is not contributory. So all these things comes. And always remember, in a syndromes, all these syndromes which we are talking about, familial adenomatous polyp, it's not only colon which gets affected. There are many other systems which get affected. Sometimes, if FAP patient, male patient, he can have genital cancer. He can have duodenal cancer. So not only you will screen colon. At 18 years, you start doing upper GI so to see about the duodenum. At 25 years, you ask the patient to get physical examination of the genitalia done for the genital cancer. So it is a multi-system involvement. So you have to screen every single system, not only colon.
Yes, ma'am.
Yeah.
Okay, so you will start at the colonoscopy by 12 years. You will start, and every 2 years you will do colonoscopy. Okay, till 20 years. After 20 years, no, you'll start calling the patient by every 4 years or 5 years. You'll start the calling the patient till 50 years of age.
Yes, sir.
So after again 50 years, if you are screening every 5 years, you have to screen the patient. If after screening for some, see, imagine if your age is 60 years, after the screening is negative, you can't avoid. You can avoid at that time. So routinely you have to call the patient every 2 to 3 years. So along with
Yes, sir.
colonoscopy, you have to do basically upper endoscopy. So what is the criteria for family history of colonic malignancy? Which criteria you will use?
We are specifically asking for HNPCC. I think am I right, Ismail? You're
Yes,
asking
yes,
for
yes.
HNPCC, right? What is HNPCC, Aradhya?
Ma'am, HNPCC stands for hereditary non-polyposis colonic cancer
Yes.
syndrome.
So in FAP, familial adenomatous polyp, you have polyps. In hereditary non-polyposis, it is hereditary, but there are no so many polyps as of FAP. There will be polyps, but in FAP there are hundreds, thousands of polyps. In HNPCC, there won't be those amount of polyps. There will be 10 like that.
Yes, ma'am.
So
So
what are the familial criterias?
what is the Amsterdam criteria,
Uh,
Aradhya?
Amsterdam criteria says that there should be a first degree relative
Okay.
uh, for who's suffering from colon cancer, or
How many
FAP must
generation?
be, there shouldn't be FMT, more than one.
More than one or more than two?
So I guess more than one,
Okay. Next.
or the pay, there should be no, the FAP should be excluded.
Okay. Next. There should be three successive generations. More than two family members should be affected. FAP
One
should be
age less than 50 or 60 is there, na?
FAP
Any
should be
one
excluded.
person that
FAP, yes, yes,
50s,
FAP should be
ma'am, actually.
excluded,
Less than
and
50.
age is less than one of the family member age should be less than 50 years. Okay,
Yes, sir.
Aradhya. So three successive generation, your two family members of close relative should be affected. FAP should be excluded, and one of the affected patients should be age should be less than 50 years. So that is your Amsterdam criteria.
Yes, sir.
Aradhya, what more syndromes you will see in relation to colonic cancer? We have seen FAP, we have seen HNPCC. What more syndromes?
We can, ma'am, see Cowden's syndrome,
Okay.
or Peutz Jeghers.
Yeah.
Then
Um,
Charcot
There are
syndrome.
some juvenile polyposis syndromes, juvenile. There are some juvenile polyposis syndromes also.
yes, ma'am.
What are different types of polyps, Aradhya? Matlab, I'm going out of history, but I just all of you. These are the very important things when it comes to your PG exam or else your questions also. What are the different types of polyps?
Types of polyps.
Yes, yes, yes. Different types of
Inflammatory,
polyps.
inflammatory polyp, that is a pseudo polyp,
Okay.
or adenomatous polyp, or
Okay.
there's a hamartomatous polyp.
And
Mm,
hypoplastic type.
yes, ma'am. Hyperplastic.
Okay.
So Aditya, this past history of hysterectomy, why history of hysterectomy is important apart from your adhesions?
If the hysterectomy might have occurred due to some uterine cancer.
Yes. So hereditary non HNPC Lynch syndrome is there, no? So most common is
Yes,
also endometrial cancer is also most common. So that's why
yes, sir.
history of asking multiple familial malignancies is important. Okay. So your
Yes, sir.
next part is
Next,
next
sir,
past
local,
past past history, personal history, and family history. Then next,
sir, general examination.
where is your menstrual history?
Okay, sir. I'm so sorry I didn't take the menstrual history in this
So
case.
that so okay, in exam no, that is a blunder. So they will fire you
Yes,
directly in exam. That females you should not face the menstrual history.
yes, sir.
Okay. So your patient is 60-year-old female patient, belongs to lower socioeconomic status. She is having main complaints of loose motion since 3 to 4 months with dull legging, lower abdominal, left lower abdominal pain. That is dull legging, constant type of pain. Release after passing stools. And there is loss of appetite, no any significant other history.
Yes, sir.
And she is known case of hypertension. Okay. So starting for general examination,
Yes, uh, in general examination, the patient was conscious, cooperative, and well oriented to time, place, and person. She was examined in a well lit room with consent. She weighed approximately 50 kgs, 50 kgs, and her height was 156 to 157 centimeters.
okay,
The
next,
BMI on calculation was approximately 20.69.
okay, next.
She was afebrile. Mm,
How to
the
assess the
pulse was
consciousness? How to assess the consciousness of the patient?
uh,
So your weight is 51 kgs.
yes, sir.
Okay. If patient is not able to stand on the weighing machine, how to check the BMI or how to check the patient's BMI?
So I don't know how to check the BMI.
So that so that is a homework for you. If patient is not able to stand on the weighing machine, and how to check the consciousness of the patient.
Yes, sir.
So in examination, no, you should not mention the temperature A febrile. You have to mention specifically because the thermometer will be available for you in the examination.
Yes, sir.
Or in malignancy, there are specific scores you have to mention, Aradhya. You're till now you're understanding this patient is a chronic patient or some sort of malignancy. So what are the scores, performance scores, any performance scores, it is a question which is little higher level than you, but there are these performance score called as Kornofsky score, all those. What it tells you is how much fine is the patient. Imagine the patient is not able to move out of the bed or not able to do anything. What's the use of you doing hemicolectomy, some sort of procedure to that patient? It is going to worsen the patient, no? So you have to know what is the status of the patient, how well the patient is. For that, you have specific scoring systems. Those are the Kornofsky score or those.
Yes, ma'am.
Okay. So next, the pulse rate is 76, BP is normal. Next,
There's absence of pallor icterus or
what is your
the
respiratory
pickle.
rate?
Sorry, sir, I forgot to mention the respiratory rate, but it was 17 per minute.
17 cycles per minute. Next, which kind of respiration? Abdominal, thoracic, or thoraco-abdominal?
Sir, it was thoracic.
So in females, you'll be having abdominal, thoracic, or thoraco-abdominal. So in females, you'll be having thoraco-abdominal.
Yes, sir.
Okay. So there is a no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. Which edema you want to see? Like you want to see pedal
Sorry,
edema
sir.
or which edema you want to see?
I
Come
don't know,
again.
sir. I saw the pedal edema which was not present.
So you have to mention there is a no evidence of any pedal edema.
Yes, sir.
Okay. So first, your differential diagnosis, you are telling patient is having chronic abdominal pain, loose motion. What you want to see in the head-to-toe examination apart, like you are telling, no, tuberculosis.
Tuberculosis,
So what are the signs of tuberculosis?
chronic
Head to
wasting, sir.
one is your wasting. Head-to-toe, what you want to see specifically in tuberculosis? Suppose this is a case of abdominal tuberculosis.
Yes, sir.
So what are the cutaneous markers of tuberculosis? This is your medicine case. Okay, so basically in medicine, no, if you are having pulmonary tuberculosis, they'll ask you. In a respiratory case, examination is RS examination. So
Yes, sir.
RS examination, you have to mention the cutaneous markers of tuberculosis. In CNS examination, you have to mention the neurocutaneous markers of CNS examination. If you are dealing with
Yes.
previous case, you have to mention the signs of atherosclerosis or signs of CCF from head to toe. So
Yes,
in
sir.
GIT case, if you are taking CLD case, you have to mention the signs of CLD or signs of hepatic cell failure. You have to mention the head to toe signs. So suppose if you are thinking this is a case of abdominal tuberculosis, so what are the cutaneous markers of abdominal tuberculosis? What is lupus vulgaris? What is scrophulodderma?
So I don't know these terms,
So
but sir, I've heard that scopuloderma is a nodule, a subcutaneous nodule.
okay,
Uh,
lupus vulgaris.
so that I
So
don't
that
know.
so that is the homework for you. What are the cutaneous markers of tuberculosis?
Yes,
And you
sir.
will be having matted multiple lymph nodes.
Yes, sir.
Okay. So in which GI condition you will get clubbing?
Clubbing can be seen in bronchiectasis
Which
or a
GI
lung
condition you will get?
abscess.
Which GI
GI.
GI condition you will get
Uh,
clubbing?
mm,
We are dealing with
clubbing
GI case.
or a clubbing can be seen in uh, sort of cirrhosis,
Okay. Then
lymphoma, GI lymphoma.
okay. Then
Mm,
so that is the
IBD,
homework for
sir,
you.
most probably.
Which IBD specifically?
So that I don't know.
So that is the homework for you. See, when you are having head-to-toe examination in all the medicine cases, so they'll ask you causes of clubbing in the GI, causes of clubbing in the CVS, causes of clubbing in the CNS, causes of clubbing in RS. So based on system, no, they will not ask if you are telling the taking the GI case, you are taking bronchiectasis, lung abscess, no. So they'll be asking you GI specific to the clubbing.
Yes, sir.
Okay, what are the causes of lymphadenopathy in GI case?
TB, sir.
Abdominal tuberculosis, then
Uh, if it's a male, then seminoma can present as a swelling.
lymphadenopathy. So if you are having, if you are telling seminoma, which lymph nodes you want to palpate?
Uh, Aorta cable and
Pre and paraaortic lymph nodes you want to palpate.
yes, yes, sir.
Okay. If it is a scrotal malignancy, which lymph node you want to palpate?
So inguinal.
So you want to palpate the inguinal lymph nodes.
Yes, sir.
So If you're telling pain in the pain at the left lower abdomen, so which side you want to see edema specifically? Suppose in terms if you are thinking it as a
Mm,
malignant.
yes, sir.
So left side pain, which side you want to see the edema? So if there is any left-sided pain, left-sided any lump is there, you want to see specifically left-sided, left-sided lower limb, that is non-fitting edema. So usually develop fitting edema, no? So
Yes,
you'll be having non-fitting edema in the left lower side. You will be having any your fixed varicocele or varicosities. Unilateral
yes,
varicocele
sir.
or unilateral fixed varicosities, those are more likely suggestion of your malignancy due to compression symptoms.
Yes, sir.
Okay, suppose if you are telling this is a case of inflammatory bowel disease. So
Yes, sir.
what are the cutaneous markers of ulcerative colitis or extraintestinal manifestation of ulcerative colitis?
Pyoderma gangrenosum can be seen,
Okay,
or anterior uveitis also can be seen.
okay.
And,
So you'll be having
erythema.
multiple mouth ulcers, erythema nodosum, pyoderma gangrenosum, anterior uveitis, scleritis. So simultaneously you'll be having clubbing also in ulcerative colitis.
Yes, sir.
So I was asking specifically IBD, so ulcerative colitis will get clubbing. So that is important. You will be having questions
Yes,
for extra intestinal manifestation of inflammatory bowel disease or ulcerative colitis, and
yes, sir.
you will be having sclerosing cholangitis.
Yes, sir.
Okay, so that are the extracutaneous markers. Next page.
Sir, this is the a photo of the patient
Okay,
on local examination.
go to the patient's photo. Okay, start your local examination now. Inspection. No, not
So
seeing
on
the
inspection, the skin.
with patient's photo. Imagine you are in front of the patient. Not by reading this slide. Go to the patient's photo. Now start your inspection.
Yes, sir. So according to the inspection, the skin over the abdomen appears to be
So
completely normal.
you are starting with inspection. What is your position of the patient? Patient is in this standing position.
No, sir. She
So
is
you
in
have to
a
tell me
supine position.
patient is in supine position. Patient is exposed from where to where?
The patient is exposed from the xiphisternum uh,
Okay.
to the hypogastrium.
Hypogastrium.
Yes, sir.
Abdomen examination is incomplete without examining your external genitalia. So you are
Yes, sir.
examining the patient from the xiphisternum to your mid-thigh level.
Yes, sir.
Okay. So this is your female patient. You are the male doctor. What you want more?
Consent, sir.
One is consent. Then you need
Presence of
female.
a
You need female
male.
attendant.
Yes, attendant.
Not
Yes, sir.
you need female attendant. Okay. So always remember when you are going to examine the patient in OPD or anywhere, while examining female patient, you need one female attendant. So
Yes,
these are
sir.
the words important because in examination, no, you will be having not only examination, while examining the examiner see all the points, how you are taking the consent, whether you are asking the female attendant, whether you are covering the patient, whether you are exposing the patient properly, whether you are covering the external genitalia properly. So in examination, not only
Yes, sir.
examining, you will be having marks for all these things. So that is called as OSCE. So you will be having marks for OSCE also. So make
Yes,
sure
sir.
you never miss these points. Okay? So you will be examining the patient with after taking proper consent, adequate exposure from your GP standard to mid high level under proper light with proper consent in presence of female attendant. So that should be your first line in all the examination. Irrespective of any hernia, hydrocele, lump in the abdomen, thyroid case, breast case, any case, you have to tell these lines first. So now start your examination, Aditya. Inspection.
Yes, sir.
Yes.
So after taking the consent of the patient, the patient is in supine position, and on local examination, uh, be seen that the skin over the abdomen is completely normal. There is no redness or a scar.
Okay.
Then the shape of abdomen appears to be normal. It is flat. It is not scaphoid or distended.
Okay.
Uh, no pulsatile mass is seen,
Okay. Next.
or no. mm,
How is your umbilicus?
the umbilicus appears to be inverted.
Umbilicus is central and inverted.
Yes, and
Is there any scar mark?
there is no visible. There's a scar mark below the umbilicus.
There is a linear scar mark present below the umbilicus.
And, sir,
And also
there is
you
no
can
visible peristal.
you can see some transverse scar also.
Yes, sir.
Okay. So those are scar hid by your primary intention. So when you are telling the scar, no, you have to tell there is a no cup impulse to rule out incisional hernia along with the scar.
Yes, sir.
Okay. So there is now your inspection. So inspection abdomen shape appears to be normal. Corresponding quadrants of abdomen moves equally with respiration. Umbilicus is central and inverted. Skin over the abdomen appears to be normal. There is a midline transverse scar hid by primary intention. There is no cuff impulse over the scar. External genitalia examination appears to be normal, and all hernial orifices are intact. So this should be your examination inspected finding.
Yes, sir.
Okay. So inspection, do you see any gross asymmetry or any lump in this patient?
No, sir.
Okay. So inspection, apart from the scar, inspection is normal. Go to palpation. So suppose if you are palpating
So
this patient only, ah, start with palpation.
palpating with the palpating
So,
upon palpate.
Arad, you have told you are going to see the pulsations. So, so you want to see the abdominal movements also, pulsation also. What will be your position? How will you see the patient
Uh,
for seeing the pulsations?
so supine position.
Patient will be supine position. What will be your position?
Uh, for seeing the pulsations, I can be at the level of the patient
So you
so
should be
that
at
I
the
can
level of the
clearly.
patient. You should see the tangentiality of the patient.
Yes, sir.
Okay, you should see tangentiality of the patient. Any abdominal pulsations, there any movements are there. Okay, next
Yes, sir.
palpation.
Upon palpation from the to the dorsum of the hand,
So
there was no.
palpation start with your superficial palpation.
Yes, sir. On superficial palpation, there was no local rise in temperature seen
So how
or
will you
felt.
compare? How will you compare the localizer temperature?
By comparing it with another part of the body.
Which part? So you have to compare the abdominal temperature with your thorax temperature.
Yes, sir.
Okay, so that is your to see the with localizer temperature. Next,
Then there is no tenderness upon palpation. There is no tenderness felt,
yes. Next,
and on deep palpation, there appears to be a mass in the lower left abdominal region.
see now you are now you are telling the examination. So you can tell your areas: left hypochondrium, left lumbar, left iliac. So not no need of left lower abdomen. So you have to
Yes,
tell
sir.
the area specifically.
On there was a mass palpated on the left hypochondrial region.
Okay.
which was approximately of size 5 by 4 centimeter.
Only left hypochondrium or left iliac region also you are having mass, or more left lumbar or left iliac region mass,
Sorry, left iliac fossa,
and your
uh,
left.
left lumbar, sir. Left
So
lumbar and left iliac fossa.
you are having mass at the left iliac and left lumbar area. So first, see,
Yes,
this is
sir.
your abdominal examination. So you have found one mass at left iliac and left lumbar area. So what is the size of
Yes,
your
sir.
mass? So it is approximately measuring.
5 into 4 centimeter.
So approximately measuring 5 into 4 centimeter. Next, how is the surface?
Uh, the surface is smooth,
Smooth surface.
and
Next,
mass has a firm consistency.
mass has firm consistency. What about the borders?
The margins are well defined,
Borders are well defined. Next,
and upon palpation, it does not show any movement with respiration.
on
Mm,
palpation, mass does not move with respiration. Whether mass moves freely in the abdomen.
no, sir. No, sir. It does not move freely.
So you
It
want to
is
tell the mass,
not a.
you want to tell the mass is having restricted mobility or mass is added to the some surrounding structure.
It has a fixed mobility.
No,
Uh,
you are telling the fixed mobility, whether mass is moving in the transfer direction, anterior posterior direction, whether mass is moving freely in all the different quadrants.
no, sir. It is not movable.
Okay. So your mass is fixed. You want to tell the mass is fixed mass.
Yes, sir.
Whether it is painful or painless,
It is painful upon palpation, sir.
like it is having mild painful is there, mild patient is having mild pain on palpation.
Yes, sir.
Okay. Tell your now all the palpate. How much is distance from your? You have to tell the distance from your midclavicular point in the
M-
subcostal margin,
Mid
from the
axillary point.
midline, yes, from midline, mid axillary, and from your midigular point.
Yes, sir.
Tell your palpation findings now completely.
So upon palpation, upon superficial palpation, there was no local rise in the temperature. There was no tenderness felt. Upon deep palpation, a mass was felt in the l- left iliac fossa and left lumbar region,
Which
of
measures
approximately, which measured 5 into 4 centimeter. The
okay,
surface of the mass was smooth. It had a firm consistency with margins well defined, and there was no movement felt with respiration, or and the mass was fixed in its position. Um,
and exact location of mass from approximately from subcostal margin.
Approx location from the subcostal margin
So
was
if you have
6,
subcostal margin 6 centimeter from your midline,
6 2 to 3 centimeters from the midline.
and your for anterior axillary line,
So it was located on the anterior line.
so it was up to anterior axillary line, and from midigular point,
Mid-inguinal point, 4 to 5 centimeters from the mid-inguinal
okay.
point.
So that is your palpation. Do you find any see one palpation and how you have to palpate at the end scar also? The scar is there, no? You have to in inspection you have seen the cuff impulse. Now you have to palpate the there is a cuff impulse. Any defect is there in the palpation or scar also. Any scar tenderness
Yes,
is
sir.
there, you have to see that.
Yes, sir.
Okay. And in palpation, and apart from that, any other thing you are seeing in the palpation, palpating anything?
Uh, I'm seeing that the mass is intra-abdominal in nature and not parietal.
So that is your plane of the swelling or plane of mass.
Yes, sir.
So how do you do the test?
It can be done with raising rising legs test or Carnet's test.
Okay. So
Uh,
what you have done head rising or
yes,
leg rising test for this patient.
leg rising, sir.
So when you are having uh, mass at the center in the recti, you have to do the head rising test. When the mass is in the left side or left lumbar areas or right lumbar area, you have to do the leg rising test.
Yes, sir.
Okay. So that is your Carnet test. On doing Carnet test, mass disappears or it appears more permanently?
Sir, it disappears.
So mass disappears completely. It suggests you of your intraperitoneal mass,
Intra-abdominal, sir. Yes, sir,
intra-abdominal
intra-abdominal
mass.
mass.
So you want to rule out whether mass is intraperitoneal or retroperitoneal. Which test you want to do?
Ballotment, sir.
Allotment.
Yes, sir. If the mass is ballotable, then it is a retroperitoneal mass.
So that is your kidney mass.
Yes, sir.
Kidney volatility is not for your retroperitoneum. Which test you want to do to intraperitoneum, retroperitoneum?
Mm,
So you want to
I
do the
don't.
patient in the knee elbow position.
Yes, sir.
Okay. What will be in the knee elbow position?
Upon knee elbow position, if it is an aortic aneurysm, it
Not
will be
related to,
more
this is not related to aortic aneurysm. If the mass is intraperitoneal, it will fall forward while doing the knee elbow position.
yes, sir.
You can feel the mass properly. But the
Yes,
retroperitoneal
sir.
mass, it won't fall.
Yes, sir.
You will be not able to palpate the mass because the small bowels or coils of intestine, no, it will come on your examination. So
Yes,
your
sir.
knee elbow position, you should put the patient in knee elbow position. You have to do the examination. If you are seeing palpating the mass thoroughly, properly, mass is falling forward, that is suggest of intraperitoneal. If mass is not falling forward, you are not able to examine the mass properly, that is your retroperitoneal mass. So to rule
Retroperitoneal. Yes, sir.
intraperitoneal, retroperitoneal, you have to do the knee elbow position.
Yes, sir.
So this is your palpation finding. Auscultation or any percussion. Only
Percussion. On percussion, tympanic note was heard over the other abdominal regions, and an impaired tympanic note was heard over the mass,
so
the
more than
area where the
impaired is
mass was.
called as dull note.
What's the I didn't
More
listen.
more than impaired note. It was a dull note.
Yes, sir. It was near about a dull note.
So it was a dull note over the mass. So there are any
Yes, sir.
signs of free fluid in the abdomen.
No, sir. There was no shifting dullness seen. Oh.
So for minimal fluid, which test you will do?
Thrill, sir. Fluid thrill.
No, no. For minimal fluid, you will do puddle sign. That is also same knee elbow position.
Yes,
For
sir.
moderate fluid, you will do shifting dullness. Fluid thrill is for
Yes,
your, like if you are having maximum 10 societies, you will do the fluid thrill.
yes, sir.
Okay. So there is no signs of any free fluid also.
Yes, sir.
And auscultation.
On auscultation, normal bowel sounds were heard,
Okay.
approximately 7 to 8 per minute.
So there are normal bowel sounds are heard, and any others
Yes,
apart
sir.
from any other all other system examination.
What, sir?
Other system examination is normal, or you have any other abnormalities?
Normal, sir. CVS and RS were completely normal.
Okay. So summarize your examination finding.
Mm, so all the examination findings, inspection, palpation.
Yes, 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 yes. Inspection
Upon
is your
inspection,
normal. You
yes,
are
sir.
not appreciating anything. Palpation.
Palpation, upon palpation, mass was felt in the left iliac fossa and lumbar region, which was 5 to 4 centimeters, which size was 5 to 4 centimeters. It had a smooth surface, with firm consistency, 6 centimeters from the costal margin, 4 to 5 centimeters from the mid-inguinal point. Uh, it lied on the mid-axillary line and 2 to 3 centimeters from the midline.
Okay.
And the mass, there was no movement with respiration. The mass was fixed in nature. It did not show any evidence of retroperitoneal growth, and the mass was intra-abdominal in nature. The swelling was not pulsatile, and upon so upon examination of the hernial sites, there was no cuff impulse seen.
So what could be a differential diagnosis?
The differential diagnosis here can be, sir, CA colon, or
Okay,
most probably, or an ovarian tumor.
okay.
It can be a retroperitoneal teratoma,
Retroperitoneal, so retroperitoneal sarcoma, retroperitoneal any keratomas, then
or it can be lymphoma.
retroperitoneal or lymphomas, then
Yes, sir, and
so it could be
sir,
any
only,
diverticulitis or diverticular abscess,
yes, sir,
because sigmoid colon is most common, no? Diverticular abscess or diverticulitis is also more common.
yes, sir,
So we'll keep these in the differential diagnosis. Okay.
yes, sir.
Uh,
Diverticular
so
abscess.
okay. So why it is not an ovarian mass? So you are missing some two examination. One is your per rectal and another one is your per vaginal
Per
examination.
vagina.
So per rectal examination, what do you want to see specifically? If there is any
Per,
growth, if there is any growth in the
yes,
your
sir,
rectum, if you are feeling any growth, or if you are feeling any nodules in the your rectovesical force, that is if you are feeling any lumbar shelf nodules.
yes, sir,
Okay, so that is your per rectal examination. Per vaginal examination, you want to see there is very any ovarian growth is there.
yes, sir,
So why it is not ovarian growth means one is while doing examination, no, that mass is not continuing, it is not going below the inguinal ligament, is continuing its ovarian part.
yes, sir,
So you are feeling the you are like your mass is above 4 to 5 centimeter above the inguinal ligament, no, mid inguinal point, mid inguinal about 4 to 5 centimeter above the mid inguinal point, no.
yes, sir,
So your mass is not going continuously in the pelvis. If it is going, if you are not able to feel the lower border, if it is going in the pelvis, it could be ovarian mass. But your
yes,
mass
sir,
is not going into the pelvis. Your mass is restricted to your abdomen because ovarian are pelvic,
yes,
usually pelvic nose, it is spread into the pelvic. So it is not
yes,
going
sir,
into the pelvis, it is related to the abdomen. So it is less likely your ovarian mass.
yes, sir,
Okay. So next investigation and management will do tomorrow or day after tomorrow. Is it fine, Aradhya?
yes, sir, yes, sir.
Do you have any other doubts today?
No, sir.
Okay, so we'll keep tomorrow or day after tomorrow investigation rest of the things management part.
Yes, sir.
Thank you, Aradhya.
Welcome, sir.